Hello, everyone. Welcome to today's CalMap webinar on complex ADHD, confounders, and comorbidities. Um, I would like to introduce, before I introduce our speakers for today, just maybe a few quick announcements. Next slide, please. If we could go on to the next slide, please. Thank you. Quick disclosures here on our activity planners and speakers, and then we have no major financial conflicts of interest to disclose. Next slide will show you a quick word about our funders from the California Department of Healthcare Services, as well as HRSA. And next slide, please. These are our learning objectives for today, but before we go into those, I would like to introduce our speakers for today. Dr. Lauren Schumacher is an associate clinical professor of psychiatry at the UCSF School of Medicine and serves as a child and adolescent psychiatrist for the Division of Mental Health and Child Development at UCSF Benioff Children's Hospital, Oakland, and the Division of Child and Adolescent Psychiatry in the UCSF Department of Psychiatry and Behavioral Sciences. She is also one of CalMap's psychiatric consultants on our call line and helps to organize continuing medical education events. Dr. Lauren Haack is an associate professor, a clinical psychologist, and chief of the School Age Youth Division in the UCSF Department of Psychiatry and Behavioral Sciences. Dr. Haack currently serves as associate director for school consultation lead on the California Child and Adolescent Mental Health Care Access Portal, CalMap. The two of them will be speaking today on complex ADHD and comorbidities. As usual, we will be saving the last 10 to 15 minutes for audience question and answer. If any questions come up for our speakers, please do use the Q&A portion of the controls to enter those questions in, and we will be sure to lift them up to our speakers or answer them by text. With that, I'll hand the virtual mic over to our speakers.
Great. Thank you so much for having us today and for being here. We're hoping that after this presentation, you'll be able to connect evaluation methods to decision-making strategies regarding ADHD and common comorbidities, be able to identify best practices for managing medications for youth with ADHD and potential comorbidities, and provide evidence-based care recommendations for psychosocial treatments and resources for youth with ADHD and comorbidities. So to start with, we have a weight question. So we want to have you type your answer in the chat, and when we say go, you can click submit. And think about when a youth presents with attention and behavioral challenges, what other conditions do you commonly consider alongside ADHD? We'll give everyone a moment to think, and then go ahead and go and submit your input. So I'm seeing some sensory processing disorder, learning disabilities, anxiety, trauma. I think I saw obstructive sleep apnea, substance abuse. Yeah, so there's a lot of different things that can come along with ADHD or kind of look like ADHD. And that's kind of part of what inspired this talk.
Okay, so as you all can probably have gathered, the majority of both boys and girls with ADHD also meet diagnostic criteria for another mental health condition. However, we see a slight difference in what those may be. So boys are more likely to exhibit externalizing conditions like oppositional defiant disorder or substance use disorder, whereas recent research has established that girls with ADHD are more likely than boys to have a comorbid internalizing condition like anxiety or depression. And about 66% of people with ADHD frequently have a comorbid condition. The other common comorbidities include learning disorders, sleep disorders, behavior, anxiety, mood disorders, and also tic disorders and toileting disorders, which those ones I don't think came up on the list. Those ones that are maybe ones that we're not as familiar with as some of the others that you put in the chat. Oh, you're on mute, Dr. Schumacher.
Thank you. It's helpful to keep all this in mind with when we think about evaluation for ADHD. And I think a helpful starting place is the AAP practice guidelines for ADHD, which recommend evaluating 4 to 18-year-olds when there's attention or school concerns for ADHD, making sure DSM-5 criteria is met, and assessing for co-occurring and differential physical and mental health conditions. And that's really going to be our focus today. So we're curious, when you're evaluating for ADHD, how do you approach evaluating for ADHD and co-occurring differential disorders in your practice? Any favorite tools that you use? So again, go ahead and type into the chat, and we'll wait a moment and can go ahead and submit. So I hear rating scales and observations. Vanderbilt looks like a common one. Craft, PHQ-9. Yeah, a lot of great thoughts. So when you're evaluating for ADHD, a challenge is that there's kind of no singles test that can tell us if someone has ADHD. And really the gold standard is comprehensive inquiry. So using multiple methods, informants, and different contexts to think about it. So thinking about kind of clinical interviews with the parent and child, getting rating scales from parents and teachers, seeing what you observe kind of when they're in your office and you're meeting with them, and looking for whether these symptoms are affecting functioning in different settings. Is it affecting just home or school or both, activities, social interactions? And getting a sense of the functional impairment. So if these symptoms are present, how are they affecting their functioning? Are they having issues with school, academics, peer problems, emotion dysregulation, family problems? Often a combination of those. And as part of this evaluation, we commonly use rating scales. I saw in the chat a lot of shout outs for the Vanderbilt, and that's a common one we use. There's both a parent and teacher version. And a nice thing with the Vanderbilt is there's an initial one that asks about inattentive and hyperactive symptoms, but also ODD, conduct, and kind of depression and anxiety symptoms. And then follow-up that just focuses on the inattentive, hyperactive symptoms. But that can be nice for screening both for ADHD symptoms as well as some common comorbidities. The SNAP is another good one to use. That one looks at the attention and hyperactivity. It also has ODD subscale as well. And then for 18 plus, the adult ADHD self-report scale can be used as a self-report, and it can be helpful kind of during assessment to get these to help with diagnosis and providing a baseline, and then kind of intermittently through treatment to see kind of how they're responding to treatment, help guide, do we need to adjust their treatment? And these rating scales can all be accessed on the CalMAP website.
Okay, so we talked about how the gold standard for ADHD assessment is really getting multi-informant information so that you can assess whether these symptoms and functioning impairments are happening in more than one setting. So for kids in the pediatric setting, that's oftentimes asking parents, which is pretty easy in primary care, and then asking teachers, which can be more challenging, right? So one thing that can be helpful is using a template that allows a consent for release of information back and forth between the healthcare and the school settings. And this is really important because we operate under different privacy laws. So in the healthcare setting, we operate under HIPAA. In the school setting, they operate under FERPA. And so one thing that can be helpful is using a template like this one, which we have up on the screen and QR coded, which was developed by the AAP and also the National Nurses Association, the National Association of School Nurses. They collaborated to develop this FERPA and HIPAA compliant information sharing agreement template consent form to facilitate that cross-sector communication. And this is available on the website in multiple forms and in multiple languages. I always like to shout out one of our partner success stories from a local FQHC network that we partner with in the East Bay. And after consulting with us about how to improve ADHD assessment in their setting, they developed a really kind of face valid, simple protocol of having these release of informations in multiple languages, and the Vanderbilts just printed out in multiple languages and cover sheets that they would send in a pack. They would put in an envelope for the parent to give the teacher or mail to the teacher, kind of explaining, this is what we're doing. We're going to ask you for these rating scales. Here's the form signed by the parent that allows you to send these back to me. And they said just having that all printed out ready to go really helped improve their ability to quickly do these assessments when needed. They also developed an EMR list so that anyone they started this process to, they put them on this list so they remembered to go back and, oh wow, it's 2 weeks later, I haven't heard from the teacher, let me reach out again. And also a protocol for scheduling behavioral health clinician follow-ups. So that might be something that inspires you all to make something that didn't take them a lot of time. It wasn't rocket science, but made a huge difference in their actual practice. Okay, another evaluation tool that I really like is just gathering information using the ABC model, or what we sometimes call the before-after model. And this is kind of a simplified functional behavior analysis, which might look familiar to some of you, might not look that familiar. But really what you're doing is you're gathering information, again, ideally from someone in the home setting and the school setting, about what is it specifically, what is the specific be or behavior that we're seeing in this child. We want it to be really descriptive, right? Like tell the parents and teachers, like almost like you're writing a movie script, so I can really see what's happening. We don't have to make interpretations or judgment calls about what we're concerned about. And then what's the antecedent? What's happening before those behaviors? What's the setting, the setup, and then what are the consequences? What are the responses from others in the environment or that are contributing to these behaviors continuing to happen, right? And then that can also help you set goal behaviors and identify what are things in the setting and what are ways that we can change our responses to the student when they, or this patient, when they are showing these positive behaviors, to encourage them to keep happening. And so we have a template for this ABC model, which is QR coded here. And then we also have a whole video from an Echo, so like a 25-minute video about how to use this model if you're interested, QR coded as well.
So here we have the kind of overall diagnostic criteria for ADHD. So you have concern, you're hearing from patient and family concerns about attention, difficulties maybe at school. You're using your clinical interview, getting maybe a parent and teacher Vanderbilt, and seeing that you're seeing more than 6 inattentive or hyperactive symptoms that have been present for at least 6 months. They're affecting functioning at school, but also in another setting, maybe they're also having trouble at home, not doing chores, losing things, not getting things done. And then there's this last question of not from another condition, so that it's not better explained by another disorder or condition. So we want to think about how to get at that piece. So on the next slide, we have a number of screening tools that can be helpful for that. Often it can be helpful to start with a general screening tool, something like the pediatric symptom checklist or the strengths and difficulties questionnaire. Might give you a kind of global overview of, okay, are there more kind of internalizing depression, anxiety symptoms, more externalizing ADHD, oppositionality challenges, thinking about the pearls for screening for trauma, call out for crack for substance use. And then if some of those are positive, then you can also dive into more detail. So if there's some anxiety concerns you're hearing, thinking about the scared or GET-7, to delve into that more deeply. If you're hearing concerns about mood symptoms, thinking about the PHQ-9 or mood and feelings questionnaire. And we have these on the CalMap website as well. And another view of kind of all those different potential differentials and comorbidities and some of the common screeners you can use to look for those. And as we talked about, comorbidities is really the rule rather than the exception. And these is also a great time to think about calling CalMap to get for more guidance and when it's a complicated picture and maybe there's ADHD, but also concerns about anxiety or learning disorder or trauma, that's always a great time to call us to get some more guidance. So another weight question, type into the chat, what do you do if a patient is meeting diagnostic criteria for ADHD, but is also scoring high on an iterative rating scale, or you're concerned that something else is going on? And go ahead and submit those. I feel like this one's a tricky question, hard to capture in just a chat, but I see consult, call CalMath, yes, yeah, those are exactly, think about those, exploring with parents, getting a sense of their perspectives and their main concerns are all good places to start. So some things to keep in mind when there's concerns about comorbidity is really kind of taking a step back and using the history, mental status exam, rating scales to kind of get a sense of if the challenges with attention and behavior seem best explained by ADHD, best explained by something else, or that seems like they're both present. And it's hard because often we're dealing with a snapshot in time. So we may not be able to fully sort out what's going on during one visit. I think a strength of pediatrics is you guys often have this longitudinal history with the patient. So you can sometimes have that perspective of like, oh, it wasn't the main issue, but there's been some school challenges for a long time. This isn't a brand new thing. Or it might be, this is a big change from where they were before. It seems like there's maybe something more acute going on. But in that snapshot moment, you can try to determine, okay, at this time, what symptoms seem the most problematic, and trying to treat those most impairing symptoms first. And then as that improves, see what's left, and then kind of work on targeting what seems to still be a challenge. And that keeping in mind, it's an iterative process, that we're not going to have a total understanding of them all at once. And it's really, as we're seeing them over time, as we're maybe treating one thing, we see what improves, what doesn't improve, and that will kind of help our understanding of the patient evolve over time. So next, we're going to kind of dive into some specific comorbidities. So one I like to start with is ADHD and anxiety because it's so common. So it's estimated that kind of between 12 to 50% of youth with ADHD also meet criteria for an anxiety disorder, and it can be a diagnostic tangle. So, if you're seeing kids spacing out in class, is that primary anxiety? Is it, that they're sitting there worrying about the test next period and then totally miss what's happening in class right now? Is it more primary ADHD? They're getting kind of distracted by everything going on around them, their neighbor making a strange sound with their pencil, and they just can't tune it out? Or is it both? When there are concerns for both anxiety and ADHD, we still kind of say it's like there seem to be a similar impairment, or the ADHD is more impairing. It's often helpful to start with kind of standard ADHD treatment. So thinking about FDA-approved medications for ADHD, often we'll start with stimulants, behavioral therapy, and school accommodations. And there is an FDA warning for stimulants to potentially worsen anxiety, but generally kind of later studies have really not seen that pan out. And if anything, they generally see that stimulants don't worsen anxiety and anything can decrease it. So we can see that kids with kind of ADHD and anxiety, as we treat their ADHD, sometimes that anxiety reduces a fair amount, especially if before a lot of the anxiety was around things like school, getting their work done, things like that. Other times, we may treat the ADHD and see there's actually still a lot of anxiety present, and that would be a time to consider additional treatment for the anxiety, like CBT, SSRIs, or both. With the stimulants, we tend to see kind of slight increases in heart rate and blood pressure. They're generally not clinically concerning, but sometimes if there's an anxious kid that's especially kind of tends to experience that anxiety somatically, so those kids with a lot of headaches, stomach aches, that sometimes they can be pretty sensitive to that feeling of their heart rate going a little faster. So sometimes they may find that stimulants aren't the best fit for them. And atomoxetine can also be a helpful medication to keep in mind for when there's both ADHD and anxiety. And there's some data that we can see improvements with both ADHD and anxiety with atomoxetine.
Okay, so what about psychosocial treatments? If we're talking about school-aged youth, preteens, even younger kids, really before kids are adolescents, we're actually going to be mostly working with the parents and also sometimes the teachers to really help them manage the symptoms and functioning. And so for ADHD, the gold standard psychosocial treatment with the most research support is behavioral parent management training. And really the goals in PMT are to increase our clarity. So we really want to have clear, realistic expectations for that child so that they know exactly what's expected of them, right? That's on the antecedent side to hopefully improve those goal behaviors we want to see, like following directions, completing home routines, using I statements and effective social emotional coping skills, right? And then also we want to be really consistent, and ideally we're doing things consistently in all their settings, so at home and at school, and talking to each other, right? Having the parents and the teachers have some shared goals and some shared language for how to encourage and reinforce those goals. And then on the consequence side of that ABC model, it's celebration, right? We want to lay on a lot of labeled praise and rewards as the child does make progress towards meeting those goal behaviors. And if this is interesting for you, our December webinar, I will be back to talk more about PMT. And we also have some recorded videos on our website as well. But what's really interesting, well, I think is really interesting, is that in one of the Hallmark ADHD treatment studies, the MTA study back in the 90s and early 2000s, subsequent analysis actually showed that youth that had anxiety in addition to ADHD actually looked like they benefited even more from behavioral parent management training than just the kids with ADHD alone. So this treatment approach may be especially indicated for kids with ADHD and anxiety. In terms of psychosocial treatments that we know work for anxiety, really we're focused on teaching the parents how to reduce their reassurance and their accommodation, right? Because it's really natural as a caring parent when we see our child in distress to give them reassurance, like, no, don't worry about that. We're not going to miss the bus. It's going to be fine. No, everyone doesn't hate you. First day of school is going to be great. Right? That feels like the natural thing to do, but that can actually reinforce anxiety, right? It actually sends the message that, yeah, there's something to worry about. That's why I'm giving you all this attention about this. And also reducing accommodation, right? Like, oh, you're really scared of going to first period. Okay, it's okay. We'll just skip first period. Just stay home, right? Because that really reinforces that avoidance, which is what we want to address when we're doing treatment for anxiety. Right. So we're going to increase the parents kind of giving the child exposure to their feared situations and also helping the child use coping skills so that they're able to tolerate that exposure. So some of you might be saying, that sounds great, Dr. Haack. Yeah, I know that PMT and psychotherapy is a great idea for kids with ADHD and anxiety, but I just cannot get all of my family's access to those resources. So we are going to show you throughout the webinar today some resources for kind of self-guided or quick provider-guided skills that you can coach your families through in a brief visit. That will hopefully kind of tie them over while they're waiting for a referral for psychosocial treatment, or might be enough for some families, right? This might get them pretty far. And so here we have on our CalMap website, we have some handouts for online behavior management resources, which are great for kids with ADHD. And then we also have some guides for supporting kids with anxiety. And then we also suggest the UCSF CLS program website, which has some tips and templates, including a template home challenge, which helps establish those clear, reasonable expectations for a routine. For example, morning routine is one of the most common impairments we see in kids with ADHD. So what are the clear expectations we're going to set for the child? And then how are we going to reward them for meeting those expectations? Here's just some external resources as well. So CHAD is the organization for children and adults with ADHD. They have fabulous free resources on their website, including these short video and handouts that they put out that teach some of these strategies to families. And then Project Empower is an online digital single session intervention for parents who have children with anxiety. And it walks the parents through those goals that I talked about avoiding reassurance and accommodation, and instead, coaching for coping strategies and exposure. And so these are free. You can give them to parents. They can go ahead and peruse them on their own time, and they're shown to be effective. The single session interventions, actually, you might think, really, like, can we really do something when an online one session intervention? And it turns out the data is pretty promising. Oops, I went. Could we go back when Dr. Schumacher?
There we go. So then the next comorbidity we're going to talk a little bit about is ADHD and trauma. And a challenge with this one is that trauma itself can present with symptoms that can look like ADHD. So kind of trauma alone without ADHD, you can see difficulty concentrating and learning in school, having trouble listening, more disorganized, seeming restless, more trouble sleeping. So there can be a lot of overlap in the symptoms. And at the same time, youth with ADHD are both at increased risk for trauma and also increased risk for developing PTSD when they experienced trauma. So, this can be a tangle as well, and it's important to consider the impact of adverse childhood experiences and trauma on attention behavior. So keeping in mind something like the pearls to be screening for trauma, and keeping that in mind when you have a patient presenting with challenges with attention and hyperactivity that may look like ADHD. If in patients where there does seem to be kind of both ADHD as well as trauma, it still can be helpful to start with kind of the standard ADHD medication treatment, often starting with a stimulant medication. Sometimes kids with trauma in addition to ADHD may be more sensitive to the side effects of stimulants. So kind of starting at a low dose and working up gradually, and having a lower threshold for either adding an alpha agonist or switching to an alpha agonist if they're having issues with stimulant medication. And that's in particular because alpha agonists which clonidine or guanfacine, may help some with PTSD symptoms, such as hyperarousal, in addition to being a treatment for ADHD.
Okay, so what are the evidence-based psychosocial treatments for trauma? Well, interestingly, most protocols for youth start with parent management training. That's almost identical, if not identical, to what you would deliver for youth with ADHD. And this makes sense because when we know what our expectations are, when we know what to expect and what the response from the environment is going to be, that consistency helps us feel safe and it helps us feel secure, right? And then the protocols move on to teaching cognitive behavioral coping skills. And often an active ingredient in trauma treatment is some sort of reprocessing of the trauma narrative, which is really a form of exposure therapy to the reprocessing of the traumatic event. So in really little kids, this can look like creating a storybook or in song, whereas in older preteens and teens, this can look more like actually writing or audio recording a full trauma narrative. Again, if you're like, that sounds great, Dr. Haack, I don't know where I would give my families access to that. There are some great resources online. So the TF-CBT, that's trauma-focused CBT, it's one of the most evidence-based approaches, has a really nice website with some free online resources in various languages. And then I'm a huge proponent for Sesame Street. They have some really nice videos that help explain trauma and trauma reactions at a very developmentally appropriate level. Okay, what about disruptive behavior disorders? So this is one of the most, if not the most common comorbidity for ADHD. Now there is controversy. There are differing opinions as to whether we should be diagnosing children with disorders based on their behavior, since oftentimes these are representative of actually ineffective interaction patterns with adults that develop over time. That being said, we do have some good information linked here about what are disruptive behavior disorders, how do we classify them, and what can be some indications for treatment. We do know, however, and this is part of the controversy of the way that these disorders are labeled and how we identify youth, that a child's background can influence how likely they are to be diagnosed with ADHD, a disruptive behavior disorder, or both. And so if we go to oh yeah, I can control the next slide. As a result of unconscious biases, providers may judge and interpret behaviors seen in oppositional defiant disorder, conduct disorder, and ADHD differently based on the race or ethnicity of a child, putting certain populations at risk for misdiagnosis. So this is unfortunate because we know that when a diagnosis of a disruptive behavior disorder is provided in place inappropriately of ADHD, there are significant clinical implications because that child does not have access to appropriate medication and psychosocial therapy treatments, as well as other supportive services. And so this lack of services can put minoritized children at risk for perpetuating the disparities which currently exist in the medical, educational, and juvenile justice system. So we think it's really important to be aware of this phenomenon so that you can try to catch yourself accidentally letting unconscious biases influence how you're identifying youth that you're treating.
And in patients with ADHD and disruptive behavior disorders, this is a time where the combined treatment of both medication and psychosocial treatments is especially important. So really trying to emphasize pursuing both kind of types of treatment. In terms of medication, stimulants, guanfacine and atomoxetine all have data that they can improve oppositional behavior in kids with ADHD. We tend to see the largest effect with stimulants, so that's generally what we'll recommend first line. And if there's issues with significant aggression despite treatment with stimulants and parent management training, then there is data to support adding risperidone as an adjunct if the aggression hasn't improved with stimulant medication and PMT.
Sorry, I'm having a little bit of trouble with the clicker here. Thanks for your patience. So, what is the rationale for psychosocial treatment for ADHD and disruptive behavior disorders? And I think this is helpful again in your work, thinking about when and why might you refer a family to something like this, particularly because I find that families can sometimes, it can actually be confusing. Like if my child is the one I'm seeking help for and they're the one with a diagnosis, like why am I the one going to treatment, right? It doesn't really have a lot of intuitive sense. And so what we know is that while medications are very effective at treating the symptoms, because ADHD is this lifetime developmental disorder where the influences are going to wax and wane over time as demands change throughout the course of development. By doing the parent management training, you're basically setting up this person's environment to be able to respond in a way that meets their needs as they grow and develop over time, and really address the functional impairments that come from those inherent symptoms, as well as the coexisting conditions. So what parent management training aims to do is teach families lifelong skills for how to take control. A lot of times they're in their office, they feel totally out of control, right? It helps them provide structure and also improves the parent-child relationship, which oftentimes is very strained at this point. And so these are some of the goals that are targeted in parent management training. Again, just so you get a sense of, let's say you have a family in your office and they're explaining their treatment to you, and you want to know, is this what is parent management training like? Are they getting what the gold standard is? So we want there to be a focus on improving the child's compliance, so following directions, accepting parents' instructions and rules, having more independence in completing their daily chores and routines. Sometimes homework is targeted, and also increasing those pro-social interactions like respectful relationships. We also can target the caregiver, right? Because we know that caregivers of youth with ADHD and DBVs often have more stress. They report more chaos in the homes. They, because of the genetic loading, might also have ADHD themselves. And because these negative interaction patterns happen over time, which we'll talk more about in that the PMT webinar next month, a focus is really on increasing that positivity and warmth in the parent-child relationship and increasing the consistency and the expectations and the consequences. Sometimes we also take a direct approach in helping support the parent and their stress and their self-care, because think about, if any of you are parents, are you a more effective parent when you're stressed out, or are you a more effective parent when you're calm and you're taking care of yourself? Right? Obviously, we all do everything better when we have good self-care. And so sometimes parent management training will include a focus on parent stress management, helpful thinking, right? Really trying to get the parent out of thinking that their child's misbehavior is a chronic, stable, global problem. Well, they're never going to get better. They're always going to be this way. There's nothing I can do about it, right? Trying to help them challenge those unhelpful thoughts. And then we also might include some, especially as the child gets older into adolescence, some skill building with them. So scaffolding their social organization and emotion regulation skills. And so we have linked here some resources. Again, if you just want to give the parent a little bit support, something in the moment, we recommend these handouts or videos. Okay, what about learning disabilities? We know that learning disorders are also one of the most common comorbidities with ADHD. And in fact, close to 1.5 of people with ADHD will also have a learning disorder. In order to diagnose a learning disorder, a psychoeducational evaluation is needed. So this is different than just a psychological assessment, which may be doing clinical interviews or rating scales about symptoms. We really need to do educational testing to compare how that child is functioning academically, and if that matches where we'd expect them to be given their IQ. And if we see enough of a discrepancy there, we say, well, wow, they have like an average or even above average IQ. So really, we should expect that they'd be at least at grade level, but we're seeing they're 2 grade levels behind in reading. That might be indicative of a learning disorder. Now, something that's tricky about this in everyday practice is these are becoming more and more challenging to find and get covered and reimbursed by insurance. Oftentimes we're seeing more and more the healthcare setting is saying, that's not our thing, that's school, go have school do the evaluation. And sometimes even if families get an outside evaluation, the school says, well, we're not going to accept that. We have to do our own evaluation. So we really recommend going the school evaluation route if you're suspecting a learning disorder. And on our website, we have some resources for how to request an evaluation. So you could give that to the family. All right, so what about treatment for learning disorders? Well, this is one of our classes that we don't really have medications that are shown to treat learning disorders. ADHD can improve focus in school, but that's not going to directly impact their academic achievement, right? And so what we see as most effective is a comprehensive psychosocial treatment, as well as classroom management. And what's important to know is that in the United States, we have laws that are there to ensure that children who need help at school and support at school get that individualized education plan and support, which could include things like tutoring under an IEP. And even if the child doesn't meet an IEP, they're not meeting that other health impairment criteria, and the IEP evaluation, they might qualify for a 504 accommodations plan. So maybe they don't qualify for needing services because they're not behind in grade level, but we think that giving them extra time on tasks, giving them preferential seating, et cetera, could help them perform better. And so here's some examples of some accommodations that can be requested in a 504 plan. And again, if you need something actually like an actual service in the school, like tutoring, that's going to happen under an IEP rather than a 504. Okay. What's the rationale for psychosocial treatment in this constellation of symptoms? Well, we see that even with medication, kids are still often going to need more support with executive functioning. And also because of these motivational deficits, it can be really hard for them to wait for far off kind of abstract rewards, right? And then also they may be exhibiting social impairment or emotion dysregulation. They have a hard time kind of getting back on track if something upsets them, or maybe they're so kind of impulsive in their seat, they're not able to take in the information in the classroom. Psychosocial treatment is really going to focus on increasing their academic enablers, their study skills. We can also target motivation by setting up things like reward plans, right? So when you complete this worksheet, then you earn 5 minutes of free time. And then often we're including a focus on behavior social skills to hopefully kind of indirectly improve academic performance. This is an example. This is a template that we have available on our website for a check-in, check-out plan. This is one of the most effective tools that we have for kids with attention and behavior concerns, where basically the teacher is selecting really clear, consistent goal behaviors for this child. They're going to give them frequent feedback because, again, it's really hard to motivate a child if they're kind of waiting for the end of the day to hear feedback on their performance, or even waiting for like the end of the report card grading period. So they're going to get that more frequent positive feedback as they're meeting their goals, and then they can turn those in for rewards. So some benefits of using behavior support plans like a check-in, check-out system. They're really resilience focused. We're setting goals for them and helping them attain those goals. They're trauma informed because those clear expectations help us feel safe. And it gives the students reinforcement for behaviors we want to see rather than just punishing behaviors we don't want to see. So on that template, that handout that I shared for you, QR code, we have these steps for how to set up these behavior support plans. I also linked another resource from Attitude Magazine, which is another one of my favorite resources for ADHD.
And then tics. So tics is another common one that comes up. So about 20% of youth with ADHD have tics. This can sometimes cause challenges, as there is on the stimulant medications, they do have an FDA warning of a risk of potentially worsening tics. But there's been some large studies done that really didn't see stimulants worsening tics at a population level. And additionally, the alpha-2 agonists can treat both ADHD and tics. So if you have a patient with ADHD and you've started them on stimulant medication for treatment of their ADHD and they're reporting some worsening tics, it's helpful to kind of keep in mind first getting a sense of kind of the baseline, like what were they having tics before the stimulant started, kind of what was that looking like at baseline. And then if it's not too bad, spending some time observing before changing the treatment. So encouraging them to let's continue the stimulant, especially if it's being helpful otherwise, and kind of see kind of how the tic progresses, because it's also the nature of tics to kind of fluctuate over time, and that kind of different tics will come as well. If it's seeming like something that it is persisting or is a significant issue for the patient, then you can always try a lower dose or try stopping the medication and then kind of seeing how they do. And if it seems like it's clearly correlated with stopping and starting the medication, then thinking about can switch to a different stimulant So switching from a mental health antidote to an amphetamine-based one or vice versa, or switching to an alpha-2 agonist that can help treat both the ADHD and the tics as well. And I think a nice thing to keep in mind with stimulant medications is that you can start them and stop them quickly and kind of see the effects pretty quickly. So if there are questions about it, you can always stop it, see how they do. Are there changes with the tic? If the tic persists, then it seems like it's likely not related to the stimulant, can resume that, or think about an alpha agonist to treat it.
Sorry, I forgot this part was me. Okay, so what about treatment and psychosocial treatment for tics? So we have a really effective psychosocial treatment called CBIT, which is the same name I know as a trauma-informed school treatment, CBITs, but it's a totally different treatment, and is shown to improve tic frequency and intensity on par with medication. So it's a really great option. And it's basically teaching people to and the family members around the child to not reinforce when those tics are happening, and to teach the child coping skills to kind of resist the urge when they feel like they want to have that tic. And there is an online program. It's not free and it's pretty low cost, so we included that for you here.
And then the last one we're going to focus on today is ADHD and sleep disorders. So this is another common comorbidity, with about 23 to 70% of youth with ADHD having sleep problems. And this is another one that can go both ways, that, if you have an underlying sleep problem like obstructive sleep apnea, that can present with difficulties with concentration, irritability, things that can look like ADHD. And those with ADHD are also more likely to have sleep problems. So it's helpful to screen for sleep disorders prior to starting ADHD treatment, to also help distinguish underlying sleep problems from side effects. So if you have a kid that has ADHD, you started a stimulant, and they're telling you they're having a lot of trouble falling asleep at night, we want to have a sense of, is that a new problem since they started the stimulant medication and maybe it's a side effect, or were they already having difficulties with kind of settling down, winding down, and making that transition to sleep, as we so often see with ADHD. And then if there are concerns for sleep disordered breathing, like sleep apnea, to make sure to evaluate and treat that first, as it can cause ADHD-like symptoms. And there's some studies that in kids with sleep disordered breathing, that ADHD symptoms can improve after adenotonsillectomy. So that's something to keep in mind as well. And then in terms of treatment, really emphasizing sleep hygiene. We know that that's the most effective intervention. So really encouraging that. I know it's often so hard, but really emphasizing that. We have some healthy sleep habits to keep in mind on the side here, but especially kind of no screens in the bedroom at night, having a consistent routine and consistent times for going to sleep and waking up. Trying to have physical activity during the day, but not right before bed, and really kind of emphasize those, check in on those. If despite kind of working on sleep hygiene interventions, they're still having a lot of trouble sleeping, there are some medications to think about. If it does seem like it's gotten worse or kind of occurred after they started stimulant medication, you can find out when they're taking the medication, see if they can take it earlier in the day, or think about adjusting the duration of action. So if they're on a long-acting one, shifting towards a medium or short-acting one, or trying a lower dose to see if that has less effects on sleep. You can also think about adding a small evening dose of a short-acting stimulant if it seems more like it's related to kind of, as the daytime stimulants wearing off, they're really ramping up, getting very hyperactive, a lot of ADHD symptoms that are interfering with their ability to kind of settle and transition to bed. Sometimes a short-acting stimulant dose can be helpful. Melatonin can be helpful, especially, it's interesting, that's one where there's actually more data for the use of melatonin to help with sleep in kids with ADHD than there is for kids without ADHD. And then can also think about either adding an alpha-2 agonist in addition to a stimulant medication or switching to an alpha-2 agonist, because often they can help with sleep as well as ADHD symptoms. Or could think about switching to atomoxetine if it seems like stimulants in particular are causing challenges with falling asleep. So then briefly to summarize, we want to keep in mind that when we're seeing ADHD, comorbidity is really the rule rather than the exception. So it's important to screen for comorbidities and also kind of be thinking about the differential diagnosis, other things that can kind of present as inattention, difficulties in school. When we do kind of see a comorbid picture of ADHD and something else, kind of thinking about, okay, what are the most impairing symptoms and addressing those first. And many of the psychosocial treatments for ADHD and comorbid disorders are similar and have kind of similar principles that of involving parents and teachers and youth. And there's a lot of similarities across the board. So keeping those in mind, really encouraging that parent involvement, because that can be so important in engaging youth with ADHD. And in terms of medications, in most cases, you really still want to follow kind of standard ADHD medication treatments and then treating comorbidities as needed. So those are
Wonderful.
our kind of takeaways, and I'll pass it back to Dr. Jung at this point.
So we have a lot of questions, but before we go there, if we can just move on to the credit claiming. Oh, a quick reminder that you don't have to figure this out by yourself. Talks like this are great. And if you've got a particular patient who has you just like really wondering, what do I do next? You can always call. So here's a phone number, here's a QR code. Moving on, our next webinar, as Dr. Haack had mentioned, will be on disruptive behaviors as well as more good clinical pearls on parent behavior management training, followed by anxiety and depression in January. We have a primary care echo that happens second Fridays from 12 to 1. If you are a primary care provider, really want more case-based discussion and more interactive learning, this is the place to go. We also have school echoes led by Dr. Haack happening on third Mondays from 9 to 10. And you can see the topics, great ones, grief in school communities and neurodiversity in students happening in December. So with that, I want to give a quick word that you will be getting instructions by email as to how to claim this credit, but you can try these instructions now. If you have questions, please contact Enyanam, and you can see her email at the bottom, and we will drop her email into the chat in just a minute as well. We have a 30-day limit as to you getting CME credit. So this is super important. When you get that email, don't delay. Go ahead and follow the instructions if you want the CME credit. You have to answer the survey and then download the certificate, because those questions, this capability won't be there forever, and we don't send out certificates separately. So this is super important if you want the CME credit. Okay, with that, more interesting stuff. But back to the questions. This is for you, Dr. Schumacher. Do you do any baseline labs to exclude other conditions, for example, an EKG before starting stimulants?
Yeah, it's a great question. So I would say in a kid that otherwise has unremarkable physical exam, family history, we don't have any kind of general labs that we recommend for everybody, or kind of EKG that we'd recommend for everybody who are concerned about ADHD. If there are other concerning symptoms, so if there is a kid who either has a family history of arrhythmias or sudden cardiac death, or maybe has a history of syncope, things like that, then that's when we would think about an EKG. Also, if you go to the CalMath website, there's a really nice guide to kind of when to think about an EKG before starting stimulants. And then the same with kind of other labs, or so if you're maybe they're having troubles with focus or like engaging in school, and there's other concerns for thyroid abnormalities, or maybe there's diet, limited diet makes you concerned for risk of anemia. If you'd want to see other things in the picture rather than just ADHD symptoms.
Okay, great. The question came about who provides PMT. We just got a typed answer, but I think it's worth reading out loud. I recommend, okay, and I'm not on their pay, a couple of online resources. Clarity Pediatrics. You can refer to them as a pediatrician, as a primary care provider. They provide parent training behavior management specifically for ADHD. They also offer Ruby training for kids with comorbid ADHD and level 1 autism. They also offer parent training for anxiety. They take a lot of private insurance, and they also take a lot of Medicaid managed care plans. So this is kind of my go-to resource for a lot of kids who need parent training behavior management. I've also sometimes turned to Triple P Parenting Online. So for about $100, you can get like this self-paced 8-week course, and it's good stuff. Anyway, moving on. This is probably for Dr. Haack. Just to clarify a little bit, I thought we want to acknowledge children's fears, but while acknowledging, we don't want to over-reassure them. Can that be fleshed out a little bit more?
Yeah, I mean, I think you got it exactly in the answer, right? So we want to kind of acknowledge one time, okay, I hear you that you're really feeling worried that nobody's going to like you the first day of school. We did our check the facts activity and, decided that that anxiety and worry doesn't fit the facts and it's not really going to help to stay home. That's only going to make you feel more anxious. So we're going to keep going with our exposure plan to go to school. And if you bring up the anxiety more about school, I'm not going to respond to it anymore because that we know that just makes it worse.
Fantastic. This may be more for Dr. Schumacher. How do you handle a parent with a history of substance use? Okay, who also has a 5-year-old child, possible anxiety and ADHD, thinking about a stimulant, and you're not finding out directly from the biological parent, but from the foster parent about the substance use.
Yeah, it's a really tough situation. I think getting, that's again a place where, careful history and kind of rapport building with the patient and family is important. I think it's very specific to the specific situation. I think that is a place where we'll sometimes maybe think about a non-stimulant first. So maybe start with an alpha-2 agonist like clonidine or guanfacine, or atomoxetine or viloxazine. And then if we try those and it's good, we stick with that. If we try those and they don't seem sufficient, then maybe we revisit the stimulant question. If there are concerns for misuse, kind of longer acting stimulants are less likely to be misused than short acting. So really this would be a kid where probably wouldn't offer short acting as an option and stick with long acting. And I think there's also ways to be creative. So if maybe the kid is mostly with foster mom but is occasionally doing visits with the parent who misuses, one option would be, can they get their medication at school? So the medication goes to foster mom, she gives it to the school nurse who then administers it when the kid goes to school. So then I think there's different ways to think through it, but it's very specific to the particular family and patient too.
I think we have time for maybe one or two more. This also for Dr. Schumacher. Can you offer suggestions on what factors you consider to decide between clonidine and guanfacine if you want to go the alpha-2 agonist route?
Yeah, they're both good options. Clonidine kind of clinically tends to be a little bit more sedating. So if I'm concerned about daytime tiredness, I would tend to do guanfacine first. But if kind of the sleep issues are particularly concerning and we're really kind of wanting that side effect of tiredness, then I might think about the clonidine first.
Fantastic. Genetic testing to choose ADHD medication. Any
At
indication
this
yet?
point, really, there's not good data to use genetic testing for kind of choosing ADHD medications.
Okay. And then finally, there has been some pretty widely publicized research on a possible link between melatonin and heart failure. So if you could speak to this, Dr. Schumacher.
Yeah, it's a great question. I would say, I think I'd say we need more data before I'm gonna change my approach in management. This was in adults. Was a correlation. So we kind of know that the people taking melatonin are different than the people who weren't. And so we know at this point whether it's melatonin versus kind of more underlying issues that were causing this. But I think at this point, this is information that we want to study this more and need more data, but to me, not an acute concern for using melatonin in healthy kids with ADHD.
Fantastic. Thank you so much. I think we are exactly at our stopping time. Huge thanks to our speakers, Drs. Haack and Dr. Schumacher. We thank all of you for sharing some of your lunchtime with us. We know you're super busy. It's wonderful to have you here. Hope to see you next month for our next webinar on disruptive behaviors and parent management training. Take care. And if you have trouble claiming credit, I am dropping the email address for the person with the technical skill to help you. So please do let us know if you're having troubles claiming credit, because we are trying to troubleshoot this right now. Thank you.